Thank you everyone for taking the time to listen to my presentation. My project is titled Distance of the Cervical-Vaginal Junction to the Anterior Cul-de-sac Measured During Vaginal Hysterectomy in Patients with and Without a History of Cesarean Section. I would like to thank Dr. Coe and Dr. Ferrando for their mentorship with this project. According to ACOG, the vaginal approach is considered to be the preferred route of hysterectomy due to improved patient outcomes and decreased costs. This table, which was part of the ACOG route of hysterectomy committee opinion, further demonstrates the superiority of the vaginal hysterectomy. It highlights the shorter operative time and improved patient satisfaction. When compared to patients who undergo an abdominal hysterectomy, those who have had vaginal hysterectomies have a faster return to normal activity. Additionally, the vaginal approach is associated with lower costs when compared to laparoscopic hysterectomies. In 2000, the Society for Pelvic and Reconstructive Surgeons came out with guidelines for vaginal hysterectomy candidate selection. Selection criteria included assessing for uterine transvaginal accessibility, uterine size, and size reduction options, and the presence of intrauterine and intra-abdominal pathology. When these guidelines were applied to 407 women undergoing vaginal versus abdominal hysterectomy, it was shown that 91.8% of those cases could be completed vaginally. Despite the ACOG recommendation and demonstrated feasibility, the number of vaginal hysterectomies performed around the country has been decreasing. One study demonstrated a decrease from 25% of all hysterectomies in 1998 to 17% nationally in 2010. The decreasing number of vaginal hysterectomies performed, despite the previously mentioned benefits, has been attributed to difficulty in performing the procedure and lack of surgeon training. As we know, the entry into the anterior cul-de-sac is a crucial part of the case. Provider's skill and understanding of surgical planes is required to prevent injury, especially cystotomy. While the rate of bladder injury during vaginal hysterectomy is low, it can lead to serious morbidity. In 2016, Balglobin et al. Studied the anatomy involved in the anterior peritoneal entry. Using a convenient sample of 22 patients and 9 cadavers, the median dissection distance from the initial vaginal incision to the anterior peritoneum was found to be 3.4 centimeters. Patients with a history of prior cesarean sections were excluded from this study. One of the factors that can further complicate the vaginal hysterectomy is a patient's history of cesarean section. Extensive scarring between the bladder and the lower uterine segment can distort anatomic planes and make anterior peritoneal entry difficult. Given that the current rate of cesarean section in our country is 31% of all deliveries, understanding how the anatomy has changed during vaginal hysterectomy in patients with a previous history of cesarean section is critical. In order to increase our understanding of anatomy in patients with prior C-sections, we aim to quantify the mean distance between the initial cervical vaginal incision to the anterior cul-de-sac entry during vaginal hysterectomy in women with a history of C-sections and compare this distance to those who have not had any C-sections. We plan to achieve this through the intraoperative measurements, which we will discuss in the coming slides. This is a prospective cohort study of patients who were undergoing vaginal hysterectomy for benign indications in the MIGS and Urogyne department. Exclusion criteria included patients with a history of gynecologic malignancy, prior uterine surgery such as myomectomy, pelvic or vaginal radiation, or anatomy distorting the lower uterine segment. In this slide, we demonstrate the intraoperative measurements that were taken. Point A was defined as the distance from the external cervical os to the initial colpotomy. Point B was the distance from the cervical vaginal junction incision to the point of entry into the anterior cul-de-sac. And point C was defined as the distance from the anterior cul-de-sac entry to the uterine fundus. According to our sample size calculation, performed with the help of our statistics department, it was determined that we would need 40 patients total, 20 with a history of cesarean sections and 20 without. We aim to recruit 42 patients to allow for a drop-off rate of 5%. Due to the postponement of elective cases during the COVID-19 pandemic, our patient recruitment has not yet been completed. We were able to recruit and collect data from 35 patients. 23 had a history of vaginal deliveries only, and 12 had a history of at least one prior cesarean section. Given that recruitment is currently incomplete, the data presented at this time is preliminary. Table 1 demonstrates our patient demographics, including characteristics such as age, BMI, race, and parity. There are no statistically significant demographic differences between those with a history of C-section and those without. Similarly, when it came to uterine characteristics, there also were no statistically significant differences in either study group. The number and location of fibroids and presence of and stage of pelvic organ prolapse were similar in both groups. Also, there were no statistically significant differences in uterine length on preoperative imaging for either group. In this slide, we have our anatomic measurement data. The mean distance from the cervicovaginal incision to the anterior peritoneal entry point in all patients was 5 centimeters. The mean distance in patients with a prior C-section was 5.4 centimeters, and in patients without any prior C-sections, the mean distance was 4.79 centimeters. At this time, that difference is not statistically significant with a p-value of 0.27. The mean distance of the anterior peritoneal entry to the fundus was shorter in patients with a history of prior C-sections when compared to those without a prior C-section, with a mean distance of 4.49 versus 6.48 centimeters respectively, with a p-value of 0.01. This finding remains statistically significant when both uterine length and weight were controlled for on logistical regression. This slide is a pictorial demonstration of our data. It isn't drawn to scale, but it demonstrates the trends that we found. When the cervicovaginal to anterior peritoneal and the anterior peritoneal to fundal measurements are taken together, there's a trend that the anterior peritoneal entry point is higher on those patients with a prior cesarean section. Our secondary objective looked to compare surgical outcomes between patients with and without prior cesarean sections. When looking at blood loss, operative time, days in the hospital, and composite complications, there were no statistically significant differences. However, the data was not powered for these results. So in the prior study by Balglobin et al., the distance from the cervicovaginal junction to the anterior peritoneum was found to be 3.4 centimeters. But this was looking exclusively at patients with no prior cesarean sections. In our study, the mean distance in all patients, those with and without prior cesarean sections, was 5.0 centimeters. While not statistically significant, the trend showed that the mean distance was farther in those patients with prior C-sections. Additionally, the distance from the anterior peritoneal entry to the fundus was shorter in patients with prior cesarean sections. According to the trend demonstrated by our data, it is suggestive that the anterior peritoneal entry point is at a higher location on the uterus in those patients with a prior cesarean section. It is possible that this may be due to the anterior lower uterine segment scarring that develops following the cesarean section. We also demonstrated that there was no differences in operative outcomes for vaginal hysterectomies in patients with and without prior C-sections. While we do see these trends, completion of data collection and analysis of finalized data is needed before any conclusions can be made. As elective cases are rescheduled, we hope to complete our patient recruitment and data collection for the additional 8 patients with prior cesarean sections. We will then run this final data. An abstract was submitted to AAGL where we hope to present this finalized data. These are my references. And again, I would like to thank Dr. Ko and Dr. Ferrando. I'd like to thank Meng Yao in our stats department and Nita Falwell and all of the research coordinators who helped with this project. Thank you.